Good afternoon, everyone.
Good
On behalf of
afternoon.
FFPAI, I welcome you all once again today with a mega webinar with 4 learned speakers today from Ahmedabad. We have chosen different topics today. All topics are different. We have got learned speakers who will be joining us in during this 1.5 hour journey. So without much ado, I welcome you all of you again, and keep joining us in such programs in large numbers. And I hand over the further proceedings to Dr. Preeti Shankar. Dr. Preeti, please.
Thank you, Dr. Pragnesh. On behalf of the President and the Secretary, Dr. Pragnesh Shah and Dr. Pragnesh Vacharajani, I welcome you all. I welcome today's speakers. There are going to be 4 talks, and the first talk will be by Dr. Tarun Dave. And to take on the proceedings from now on, I request Dr. V.K. Jagnani. He is from Jharkhand and he is going to chair the session from now on. Over to Dr. V.K. Jagnani.
Thank you so much, madam. As rightly said, we have 4 eminent speakers with ourselves on different topics, not only from cardiology, but also endocrinology and pulmonology. The first topic we are going to discuss is diabetic dyslipidemia with Dr. Tarun Dave sir. And to introduce Dr. Tarun Dave sir, I kindly request Dr. Sanjay Shah to take over. And I request all the speakers that we have 15 minutes session for each of the speakers, followed by discussion. So over to Dr. Sanjay Shah for introduction of Dr. Tarun sir.
Good afternoon, everyone. I feel very proud to introduce Dr. Tarun Dave. He is a senior interventional cardiologist of Ahmedabad, and he did his DM cardiology from AIIMS Delhi, and he got honor of gold medal. He is associated with Global Hospital, Jivraj Mehta Hospital, Rajasthan Hospital, and Artham Hospital in Ahmedabad. He has vast experience of 34 years and performed several thousands of invasive procedures. He was first to perform endomyocardial biopsy in Gujarat in 1990, and Tarun Dave has published a number of national and international papers. Today he is going to talk on subject Indian diabetic dyslipidemia request a special attention. As we all know, we Indians and particularly Gujarati people are having high triglycerides and we are having a very high risk of heart attack. So Dr. Tarun Dave will guide us about what is special in Indian diabetic dyslipidemia. Welcome, Dr. Tarun Bhai.
Thank you, Dr. Sanjay Bhai and other friends, for giving me this opportunity to get associated with you once again. And you see the topic, can somebody start slides? I think one of the fellow was to put the slides. Kindly put it on the board. You see, as you have rightly placed the subject, that as an Indian, we have a certain peculiarities how our atherosclerosis progress. And time and again, we have seen that younger patients are afflicted with atherosclerotic diseases. And there are a lot of special characteristics among the Indians in which they produce this problem. Can you have the next slide? To tell you the few, that we have a more abdominal adiposity, we have a higher waist circumference, we have a typical characteristic dyslipidemia where you see our HDL is low, our triglycerides are higher, our LDL is also higher, and we have a higher insulin resistance. So there is an increased susceptibility to type 2 diabetes and CKD. CAD, because of the higher insulin resistance, you are likely to have both diabetes as well as the CAD because of the dyslipidemia. Next one. And obviously, if you become aware about these issues right from an early point of time of a life of an individual, probably you can, very well prevent it from occurring into a clinical manifestation. So diabetes and dyslipidemia, which goes together, will have a very high chance of developing atherosclerotic disease. So there is a need to be aware on part of the medical fraternity, and then also to implement among the individual persons so that we can prevent the manifestation of this deadly combination in a younger population. Next one. So can you continue the slide? Yeah. You see, there are some reports which have shown that if you come across somebody whose HbA1c is more than 7 and he received an intensive treatment within 1 year of finding an HbA1c more than 7 against those who received it before. See, the one who remained without a proper glycemic control for less than 1 year, and the one in which the glycemic control was started, the intensive treatment for the diabetes was started little later. I think the occurrence of the different problems are different. Next one. You see, this is showing that if you have a bad glycemic legacy, you see there is something called a metabolic memory in the body. So if you have maintained an uncontrolled diabetes, which is reflected by your HbA1c more than 6 or more than 7 for a longer period of time, and if it is remain so, say for 5 years, then you will have a 67% higher chance of getting a myocardial infarction, stroke, heart failure, and composite cardiovascular events. Probably what we see today in younger populations who are suddenly getting, you see a sudden cardiac death, underlying possibility of an, I would say, the borderline dyslipidemia as well as the diabetes by our strict definition that their HbA1c may be more than 6 plus lifestyle factors which pose them for a more chance of cardiovascular events. And this is what today we see time and again, which is coming up in the news channels and the other medias, that we get a higher incidence of the sudden cardiac. So if you control the glycemic control quite early with a focus on dyslipidemia, then probably you are likely to see the reduction in the cardiovascular event in next 5 years. Next one. And you see, now we have a very potent drugs, oral, other than the insulin, which is helpful in reducing the HbA1c. Let's say if you have a combination of, you see the dapagliflozin or with this thing, the sexagliptin, and if you start it, say if your HbA1c is more than 9 with metformin, compared to a combination of metformin and this thing, the dapagliflozin or metformin and sexagliptin, if you combine these three together, then you will get a much higher or better response in terms of a reduction in HbA1c. The more the baseline HbA1c, you get a more profound effect by adding a dapagliflozin plus sexagliptin combination. Next one. And dyslipidemia is also very prevalent. The prevalence of the dyslipidemia is that nearly more than two-thirds of our patients are having a dyslipidemia. So quite a sizable proportion of our patients, and this probably reflects the change in the lifestyle and the consumption of the food which we consume, which may be probably responsible for such a high prevalence of dyslipidemia in our patients in today's time. And if you start statin, then still nearly 45 to 50% achieve the LDL-C goals. And if the patient is on other statin plus other lipid lowering drugs, probably nearly 50 to 60% develop better control or better control as far as the LDL-C measurement is concerned. So treatment is very important in these patients to reduce the LDL-C level. Next. The risk of cardiovascular disease is higher for Indian patients is because in compared to the other population, you see, we get the disease at a much earlier time. That 10% of the heart attacks occurs in younger patients, that is less than 40. Today, not just 40 years, even less than 10, 30 years also we get a patient with myocardial infarction or acute coronary syndrome. And nearly 50% of the cardiovascular death occurs below the age of 70 years. So, dyslipidemia is one of the strongest contributor of developing acute coronary syndrome in the Indian patient at a much younger age and have a more diffuse disease if you see the coronary anatomy. Next one. So there is a definite need that we should reduce the dyslipidemia and we should advocate the control of the lifestyle modification, the improvement in the lifestyle changes has to be, and the physical exercise has to go right from beginning. But over and above this, if you can add the proper statin therapy, then you can reduce the LDL by 39 milligram per deciliter if the statin is started in time. And the statin, the advantage of statin is that major coronary event, need for coronary revascularization, stroke, any vascular death, or total mortality. All these various parameters of measuring the cardiovascular events are significantly reduced by tune of about 20% if the statin therapy started much at a proper time. Next one. Yeah. So, and this lipid compared to the other factors, like there's so many factors affects, like the systolic blood pressure, HbA1c, lipids, the analysis of the cardiovascular risks of patients with type 2 diabetes from the very famous UKPDS risk engine shows that the lipids contributes to a greater extent in cardiovascular risk reduction in diabetic patients. You see, this UKPDS risk engine is developed as an epidemiological tool to calculate the risk of different parameters in patients with type 2 diabetes and compared to the other parameters like the level of HbA1c or the systolic blood pressure. You see, the cardiovascular risk reduction is greatly achieved by controlling the dyslipidemia. So this is very important, and it underscores the need for better control of dyslipidemia. Next. And when should we start? I think the earlier is better. If in the younger populations, like the school-going age, it is better that they adhere to a better lifestyle so that it works as a primary or primordial prevention and do not allow the patients to develop a clinical manifestation of atherosclerosis. But if you come across an individual who has a dyslipidemia, plus there is a high coronary risk factor profile, there may not have typical symptoms of acute coronary syndrome, but you need to investigate these patients and start treatment at the level of risk factor so that you can prevent the further progression of atherosclerosis and probably delay or stop development of the acute coronary syndrome later on. So the other, if you come across a patient who have a clinical atherosclerosis like the unstable angina or acute coronary syndrome, or patients have come to you after the complications of SCS, like the heart failure, then probably you need to be starting the therapy as early as possible for the prevention of the other subsequent complications. Next one. And there is a one case example for how to start statin therapy for a goal of primary prevention. Next one. You see, one of the trials, which was a Jupiter trial, has shown that the rosuvastatin helps in reducing the LDL-C level by more than 50% in a year. And that is one of the goals of starting a statin therapy, that you reduce the LDL-C goal by more than 50% with a proper rosuvastatin therapy. And this is also helpful in reducing the inflammatory markers like, say, HSCRP. So you have a reduction in the HSCRP, triglycerides, and LDL-C is reduced by more than 50% by starting the proper dose of rosuvastatin, as demonstrated in the Jupiter trial. Next one. And rosuvastatin treatment actually helps in all clinical facets of presentation of atherosclerosis, like, say, in patients who have an unstable angina or acute coronary syndrome, then all composite of all-cause death, the fatal or non-fatal myocardial infarction, CV stroke, need for revascularization, or the composite of MI, stroke, need for revascularization, and total and cardiac mortality, all are reduced by the rosuvastatin therapy. Next. So that is mainly because of its positive effect on the LDL-C as well as LDL-HDL ratio and non-HDL-C, which is very important parameters to follow the patients who have evidence of atherosclerosis and you started him on a rosuvastatin therapy. Next one. And next one. Now, some of the patients are being just put on 5 milligram of rosuvastatin. I think we need to revise this kind of an approach. We have to go by the guideline and what is the risk of developing a cardiac event in that particular patient, and accordingly we should monitor their lipid parameters and start focusing particularly on controlling the LDL cholesterol, depending upon the risk factor profile. And this is what has been quite emphasized in the recent guidelines. Next one. Like, say, they say that if the patient has already demonstrated clinical atherosclerosis, like, say, the patient has an unstable angina or MI, or patient has a severe CKD whose GFR is reduced less than 30, or on an imaging, there is an unequivocal finding of an atherosclerosis, probably you need to be very aggressive in reducing the LDL-C, and your target should be to bring it down to 55. So either you start with a statin and follow them up, and today we have an availability of the non-statin therapy which can be added, like, say, you can add ezetimibe or you can add bempedoic acids. These are the drugs which can be added, or you can add the certain other agents which has come and which are likely to come to reduce the risk in this particular patient, as compared to those who have a lower risk or moderate risk, where the goal is of the LDL is 100. So it depends upon the subgroup of the patient, whether your patient has already manifested the atherosclerotic disease, or your patient is at a lesser risk, then you can allow them to maintain their LDL to little elevated level. But that needs to be followed in day-to-day clinical practice. Next one.
With due respect, sir, if 15 minutes are over, we have 2-3 more minutes, sir.
Yeah, sure. So this is just a repetition. Next one. And obviously, then whenever there is a discussion, most of the trials are done on an innovator brands, and whatever conclusion or the inferences be developed, they are based upon the innovator brands. So whenever you use other brands, we need to ensure that the quality matches with the innovator brands, and only then you expect the similar kind of result. If there is going to be an impurity in the other brand, then it will be very difficult to appreciate you get the same kind of a response. I think I will hand over here, but we will have some discussions, live discussions with the friends about this thing, on this topic. Yes, sir. Thank you.
Thank
We
you so
taking
much, sir.
questions just now? Are we
Uh,
taking questions just now or later on?
I guess we should take it at the end or after all the 4 talks. That should be
But
fine. If
Dr.
if sir
Tarun
is
Bhai,
waiting,
Sir, we
if
will
sir
leave
is
it till
waiting.
the end, sir.
I think we can take questions just now only.
Okay,
Yeah, I
fine, sir.
think that will be better.
Any questions for sir? तरुण सर के लिए कोई question है? I have one query, sir.
Yeah.
What is the place of saroglitazar in diabetic dyslipidemia, sir?
Yeah, well, I think you can consider, but it cannot replace statin.
Definitely,
Some
sir. It
people
cannot.
have a feeling it cannot replace statin because tiroglitazide has a more effect on the triglycerides.
Exactly, sir.
You see, so the goals are first to control your statin therapy, your LDL level, and once your LDL is controlled, and if still you have a problem with the triglycerides, probably you can consider. Anything Dr. Jay wants to add?
And
So
sir,
is it
how
true?
long?
Is it true
Yes.
that initially we should we should use a higher dose of
No, sir, I think
statin?
I completely agree with Tarun, sir, that diabetic dyslipidemia and
Yeah, the question is that we should use a high dose. That's what the question is.
Yes.
Yes, sir.
Yes.
Yeah, no,
Initial
it
high
depends.
dose.
It depends upon that subset. As one of the slides showed, that suppose you have a
Yes.
patient who had already had a atherosclerosis manifestation, like say he had unstable angina, or he had a myocardial infarction in the past, or he had undergone some procedure, you see, or he had a CKD with a GFR of less than 30, or he had a diabetes of more than say 10 years duration and more than 3 risk factor profile. These are the patients who are at very high risk of developing future cardiovascular events. In this, we should use the statin as an moderately intensive statin therapy, that is either 20 or 40 milligram of rosuvastatin or 40 or 80 milligram of atorvastatin. And then you call the patient in follow-up and see whether you have achieved the LDL goal. Sometimes it happens that patient will respond nicely to the lifestyle modification as well as the statin therapy, or sometimes you will find that they will not be able to achieve the goal. If they have not achieved the goal, you can add other therapy other than the statins. Like say you are giving 40 milligram of rosuvastatin, still it is not achieved. Then you may add something like ezetimibe, 10 milligram. If it is still not achieved, see him in follow-up, say at the end of say 6 weeks to 8 weeks, then see that what is his trend of LDL-C. If it is still not achieved, you can add something like bempedoic. Like say I have one of the patients who have a severe diffuse triple vessel disease, young fellow, 38 years, and his LDL was not controlled with 40 milligram of rosuvastatin. I had to add ezetimibe as well as I have added bempedoic acid. And now his LDL is well controlled.
Thank you. Thank you so much, sir. Thank you, Dr. Sanjay. That was a wonderful session from Tarun Dave, sir. For the next session, I request Dr. Jay Shah to take over. He will be talking on role of SGLT2 inhibitors in heart failure. And to introduce Dr. Jay Shah, sir, we request Dr. Preeti Shankar to kindly take over. Over to Dr. Preeti Shankar.
Thank you, Dr. Jagnani. It is my proud privilege to introduce Dr. Jayasha. His name may be short, but not his achievements and his qualifications. He is a senior intervention cardiologist and HOD at Department of Cardiology at HCG Hospital, Ahmedabad. He is also a teacher in DNB Cardiology at HCG Hospital again. He was the founder member and the vice president of Krish Heart Foundation, where he consults. He has many achievements to his credit, including the Gujarat Ratna Gaurav Award received from Honorable Speaker Nimaben Acharya, and also with Gujarat Legislative Assembly in 2022, as recent as May 2022. He has fellowship of ACC, FACC, ESC, FESC. We don't understand all those associations. And his special interest is in complex coronary cases. And as you can see, he's straight from the cath lab. He's joined us today to give his valuable inputs. He's been the principal investigator and co-investigator in multiple studies, including the Tuxedo and the Credence, and he's a part of the hypertension registry too. And to listen to him, we are all eagerly waiting, sir. Over to Dr. Jay Shah.
Thank you.
Thank
Thank
you,
you so
thank
much,
you.
madam. For next 15 minutes, we have Dr. Jay Shah with us. Kindly share his slides.
Thank you, Priti ma'am. Good afternoon, everyone, all the senior faculties and the dignitaries. So the topic which has been given to me is regarding the role of SGLT2 inhibitor in heart failure. Can someone share the slides, Nimish?
Rahul, yeah.
Next, please. So the topic which has been given to me is regarding the role of SGLT2 inhibitor in heart failure. Now, as we saw that in last talk, Dr. Tarun sir has already given the idea regarding the global burden and the impact of dyslipidemia in Indian patients. Similarly, when we are talking about heart failure is something in last 1 decade that it has completely converted all the attentions from coronary artery to the development of, or rather prevention of, not only the development of incipient heart failure, but the development of overt heart failure and refractory heart failure. Why is it important? Because each hospitalization will bring the patient closer to the mortality. That can be prevented with the help of a proper medication.
So one
with
minute.
The help of,
can you be a little louder, sir? Coming closer to the mic, maybe.
Actually, I'm wearing the AirPods. I'm able to hear you very clearly, but are you able to hear me now?
Yes,
Yeah, it's better.
Okay. So should I proceed?
Yeah.
Okay. So in that case, I think the role of heart failure and overall quality of life and the development of, or rather prevention of refractory heart failure is something which is of utmost importance. Next. So as a physician, what is what we remember is that which is that sweet spot or which is that cases. That particular phase is getting admitted, patient is getting stabilized in the hospital and then getting discharged. Now, after discharge, you have to have a very vigilant monitoring as far as the follow-up of that patient is concerned because they are having chronic heart failure as a condition. And this period of vulnerability can be taken care with the help of a good pharmacoinvasive strategy. Next. Now, readmission and mortality, they are almost always common in a patient with established heart failure. And we see that with each admission, there is a financial burden, there is a like the burden over the mental psyche of the patient. And ultimately, the whole family is getting disturbed because of each admission. Next. Because each admission, whether it is heart failure with a reduced ejection fraction, mid-range or preserved ejection fraction, it will soon lead to the development of mortality in those patients who are having recurrence of admission. And here you can see that from the day of inception of heart failure, where the patient is getting admitted, the mortality is hardly 5%. As the day passes, as the admission happens, as the recurrent admission happens, you can see that in a span of 5 years, that mortality is having a whooping rise of almost 50 to 70%. And that is the reason I think it's our prime duty to select and to choose our patients of heart failure to receive the best possible treatment. Next. Next, please. Next. So, as far as the overall guideline is concerned, what do we have as far as the evidence is concerned? Now, in the evidence, you can see that the guidelines which are being published very recently for reduced ejection fraction in ESC 2023, they suggested that SGLT2 inhibitor, RNA group of drugs, beta blocker, and MRA antagonist, they have to be as a cornerstone of therapy for all the heart failure cases. Having said that, what do we have for mid-range ejection fraction and preserved ejection fraction? Now, by definition, mid-range ejection fraction is ejection fraction ranging from 40 to 49%, and preserved ejection fraction means ejection fraction more than 50%. So the management of the patient having FRF and developing mid-range heart failure is probably being treated as same as that of a FRF. What is required is to give injectable diuretic for those who are having hypervolemia or any sort of fluid retention, which can be taken care of with the help of injectable furosemide or torsemide. Along with that, if there is a mid-range heart failure, you can have a role of dapagliflozin and empagliflozin as a class 1 indication to be used. While in a patient with preserved ejection fraction, for the hypervolemic state, you can use injectable diuretic. Along with that, there is a class 1 indication for DAPA or empagliflozin, which is an SGLT2 inhibitor. And ultimately, for HFpEF, it is always better to treat the etiology. Like, what is the etiology of that patient to develop heart failure? And this etiology of HFpEF is mainly related to CKD, obesity, atrial fibrillation, uncontrolled hypertension, and all this condition and comorbidity leading to the development of preserved ejection fraction heart failure. Next. So with the understanding of this background, what do we have in our basket as far as the guidelines are concerned? One thing is very sure that we must do the intensive strategy for the patient of acute heart failure, because acute heart failure can lead to life-threatening arrhythmias, can be a life-threatening condition as well if you do not treat it in a proper time manner. And that is the reason the initiation and rapid up titration of the evidence-based treatment before the patient is getting discharged, after the patient is getting stabilized, and the patient should be kept under vigilant monitoring for first 6 weeks, has got a class 1B indication. Next. So with that, what is required to remember is that all these patients of acute heart failure, when they are in ICU, they should receive injectable diuretic. Once they are getting proper treatment, once they are getting stabilized, they should be started with dapagliflozin as a SGLT2 inhibitor, which has got a 1A indication, because if the patient is in the hospital, you are very sure about the initiation, you are very sure about the up titration, you are very sure about the adherence to the therapy, the overall drug adherence will improve on the patient compliance hospital before discharge. Next. So that at the time of discharge, all these 4 pillars of the therapy, that is ARNI, beta blocker, MRA antagonist, and SGLT2 inhibitor, they are there as a part of treatment for all those cases of chronic heart failure or the stabilized patient of acute heart failure. Next. The potassium mechanism, we all know that SGLT2 inhibitor is responsible for improvising on the endothelial function, improvising on the heart genetics, the reduction in the sympathetic activity, improvement in the erythropoietin production, and down regulation of the inflammatory process. And all these things will ultimately lead to improvised survival. Next. Next. So all this GDMT, that is guideline directed medical therapy. Next, they have suggested that there is a rationale of usage of SGLT2 inhibitor in hospital, because by giving in hospital SGLT2 inhibitor, you are very sure about the compliance, you are very sure about the hemodynamic monitoring, you are very sure about the other side effects, you are very sure about the volume status of the patient, and also you are very sure about the development of any sort of urinary tract infection when you have started this SGLT2 inhibitor. That is the reason all the clinical benefits and the net clinical benefits are going to be preserved for all those patients who are of heart failure category. Next. So in that case, when we are talking about a supportive evidence, this is the evidence of a cohort study which was being published by Park et al., where you can see that the outcome, cardiovascular outcome, once the patient is being started with SGLT2 inhibitor after acute heart failure, it has definitely improved on the survival rate. Next. Whether it is related to the heart failure readmission, whether it is related to the CV mortality, all these things, you can see that this particular chart has shown a green signal for those who are having SGLT2 inhibitor as a part of treatment. Next. So the role of SGLT2 inhibitor in heart failure, it has been evolved in last 7-8 years, and you can see that after EMPA-REG outcome, after the trial of declared-TIMI, DAPA-HF, and DELIVER, all these things, they put the patient, or rather the condition, as a class 1 indication to be used as in all the category of heart failure cases. Next. The most important trial is DAPA-HF. Why it is important? Because you can see that the graph is being separated as soon as after 28 days. So within 4 weeks, you are having a statistically significant data with dapagliflozin as compared to placebo. And placebo means standard care of therapy, where there is a reduction of all-cause mortality by 17%, there is a CV death reduction of 18%, and there is a reduction of the worsening of heart failure by almost 30%. Next. Not only that, after deliver, you are having a significant role of dapagliflozin in a patient with preserved ejection fraction. And here, the graph is being separated soon after day 13. So within 2 weeks, you are going to have a beneficial effects with 18% relative risk reduction as far as the CV death, composite of CV death, heart failure, and heart failure visit is concerned. Next. So we have ample of data as far as the dapagliflozin is concerned, whether it is DAPA-HF, whether it is reliever, right from reduced ejection fraction to preserved ejection fraction, it has got a mortality benefit. Next. Now, as a physician, what is required to remember is that what should we see in patient when we start with dapagliflozin? Next, we need to see that whether the patient is having a proper volume status or not, whether the patient is having ejection fraction normal or not, whether the patient is having any sort of infection in the body or not, whether the patient is having reasonably controlled sugar level or not. Because dapagliflozin is having a glucose-dependent mechanism. It will produce glycosuria. You might be having a rise in the glucose level in the urine. So when you have a high fasting level, the chances of urinary tract infection and fungal infection are more. And that is the reason you have to be very careful in choosing the molecule, especially in a diabetic heart failure cases. Next. Now here, when we are looking at the ejection fraction, all this spectrum, they've shown a beneficial effects in heart failure. So it has got a mortality benefit as compared to any other SGLT2 inhibitor as far as DAPA-HF and DAPA-CKD is concerned. So not only heart failure, but the renal composite endpoints are also having a beneficial effect. Next. Now coming to the life-saving dapagliflozin, which is proven to reduce the risk of CV death. You can see that there is a EMPA-REG outcome trial with EMPA, which has shown a 38% CV death reduction. But here, when we are talking about DAPA-CKD, DAPA-HF, DAPA pooled analysis, all they've shown a significant all-cause mortality, which is proving the importance of DAPA as compared to any other SGLT2 inhibitor. Next. So what I think is that first one should know about the volume status, one should know about the sugar level, one should know about the blood pressure level of that patient, and then start this therapy in all heart failure cases without fail, irrespective of the status of diabetes, irrespective of the status of HbA1c, where you can straight away start with this therapy, which is going to be more beneficial. Next. Next. Coming to the important part, which has already been taken by even Tarun sir, that what is the level of evidence with innovator brand as compared to the generic part. We are very sure that when we are using innovator brand, we are very sure about the effect. We are very sure about the overall the purity of the molecule, and that is the reason you are going to have a better mortality benefit as compared to any other generic molecule. And now the benefit of this drug is that it has got a very cost effective. There is hardly any difference between generic and the innovative brand. So you can always give the benefit of this drug to be used in a patient with heart failure. Thank you so much for the quiet listen. Thank you.
Thank you so much,
Over to
Dr.
Preeti, ma'am.
Thank you, sir. Thank you for this enlightening talk. I request the technology team to see if there are any questions on their viewers link, and please share it here in the chat box. In the meantime, sir, I have a question for you. Is there an indication or there is a role for SGLT2 inhibitors in obese individuals who have grade 1, or maybe it's just that, not relative heart failure, we could say, like even one climbing one floor, they get breathless. So is there
So,
a role?
ma'am, it's a very good question, ma'am. Obesity itself is responsible for producing elevated anti-proBNP. And once it is being elevated, provided the proportion of anti-proBNP is almost 2 times than the upper limit of normal, that is putting that patient at a category of FPAF, or heart failure with preserved infection. And that category of patient should and must receive this particular drug. As a blanket statement that all obese should receive SGLT2 inhibitor, that should not be the case. The drug which is required to be given is only when there is an elevated anti-proBNP, by which you can diagnose if the patient is having preserved ejection fraction heart failure. And on echocardiography, there should be an evidence of diastolic dysfunction. And then there is a scoring system, which is known as FPAF score. It is having a heavy, that means obesity, high blood pressure, and there are certain like ceiling pressures, echo parameters like E by A dash. There are parameters which is going to put the patient at a high risk of diastolic dysfunction. All these things are as a part of category of that scoring system. Once this scoring system is having score of more than 5, that patient is having an established case of HFpEF. And it's very easily available. It is available on MedPlus calculator, on net, freely available. You can always use this calculator, which can be easily used for the patient having a heart failure.
What is the score called, sir?
HFpEF score. It is known as HFPEF score.
Okay, sir. Thank you, sir.
Thank you.
To diagnose heart failure, which will be better, echocardiography or anti-proBNP?
The echocardiography should be the first thing which should be done, because that will give you the idea about the ejection fraction, whether we are dealing with reduced ejection fraction, mid-range, or preserved ejection fraction. That is number one. The prognostication can be done with the help of anti-proBNP, because elevated anti-proBNP, which is remain unrecognized, will put the patient as having a poor prognosis. So that patient, if the patient is being picked up early, you can always improvise on their survival rate.
Dr. Jayesh, I have a question for you. Where do you place diuretic in the era of SGLT2 inhibitors when we are treating heart failure?
So as I told you in this particular slide set, that those patients who are having hypervolemia, that means the patient is fluid retention. The patient is having edema, leg edema, puffy face, abdominal edema, abdominal wall edema. All these are the factors which suggest that there is a fluid collection in the body, and that requires injectable diuretic. Now, having said that, it's very easy to see the 2D mode on a simple sonography and evaluate the inferior vena cava. Just by putting a probe, you can see that the inferior vena cava size. If that size is having more than 15 millimeter of mercury parameter, that means patient will require injectable diuretic. If it is remaining between 12 to 14, you can manage the patient medically. And if it is having less than 12, you might have to give little more fluid for that patient to develop or to prevent to develop any sort of renal azotemia. So all this can be done only by putting a single probe at the level of infravena cava, which can give you the diagnosis of whether the patient is hypervolemic, hypovolemic, or euvolemic.
And what is the place of ARNI?
ARNI has to be there for all HFrEF cases. Now
Exactly.
the era has come that you must change from ACE inhibitor or ARB as a separate molecule and give the benefit of ARNI, because even a small dose of ARNI is going to give you the mortality benefit.
Thank you. Thank you so much.
Thank you,
With
sir.
due permission from Dr. Preeti, may we move to the next session? We have interesting session with Dr. Rahul Jalan on eosinophilic asthma. We all talk about bronchial asthma, and today we have a specific topic here, eosinophilic asthma. And to introduce Dr. Rahul Jalan, I request kindly to Dr. Geeta Lodh to take over from this point. Over to Dr. Geeta Lodh.
Thank you, Doctor. Good afternoon and a very warm welcome to everyone who is logged in to today's session. I, Dr. Geeta Lodh, am delighted to introduce the very eminent Dr. Rahul K. Jalan, practicing as a consultant and interventional pulmonologist in Ahmedabad. His special interests include interstitial lung diseases, severe asthma, ABPA, and interventional pulmonology. His academic achievements include MD in General Medicine, DNB Pulmonary Medicine, and European Diploma EDARM, Fellowship in Interventional Pulmonology, and Fellow of College of Chest Physicians, FCCP, in 2023. His work experience include being Director of Chest Diseases Clinic Ahmedabad since October 2016. He is actively involved in spreading awareness and education amongst the community regarding the myths and facts related to pulmonary diseases, role of inhaled therapies in pulmonology practice, hazards of biomass fuel, smoke, and cigarette smoke exposure. He is managing a successful pulmonary rehabilitation program for improving the quality of life of patients suffering from chronic lung diseases. He has multiple publications to his credit and has been faculty at various biopsy techniques, webinars, panel discussions, and screenings of lung cancer. His thesis topic is diagnostic efficacy and complications of transbronchial lung biopsy in respiratory diseases. He has attended a multitude of workshops, done paper presentations, and won awards. He will be enlightening us on the topic of eosinophilic asthma and how to manage these patients. Over to the illustrious Dr. Rahul K. Jalan. The stage is all yours, sir.
Good afternoon, everyone. Thank you, Dr. Geeta Lodh, for a beautiful introduction. I'm really sorry that I could log in a little bit later. And also, please bear with me. I am suffering from flu and cold, so I would be coughing in between. And I'll try my best to make sure that I put all the points for which I am here very properly. So today we will be discussing on eosinophilic asthma. Normally, what we do or what we have learned is bronchial asthma. It is a huge term now because now, as a pulmonary specialist, as a person handling severe asthma clinic, we need to specifically identify what type of asthma our patient is suffering from. Is it a Th2 high type? Is it a Th2 low type? Even if you have a Th2 high type, we again differentiate and we separate the patients into an eosinophilic asthma and an IgE mediated asthma. So approximately in our country, we have more than 2.5 crore patients who are suffering from bronchial asthma. Out of this, not even 30% of the patients are receiving a proper treatment. This small group of patients who are actually difficult to treat asthma or who have severe symptoms, there is a very small proportion of these patients. But what happens is that in our practice, only these type of patients are referred to us. Rest of the patients are being taken care by their family practitioners, by their local physicians, and other specialty doctors. So when we are talking about this phenotype of patients, that the patient has severe eosinophilia. So how do we approach them? What do we do? So I would try to shed some points on that topic. Now, what is the importance of severe asthma clinics? As I said, that we have more than 2.5 crore active asthma patients in our country, and we see that the incidence is increasing in our population. So, with an increasing incidence, with an increasing prevalence of the disease, we will have more and more severe asthma patients. So the importance of severe asthma clinic is like we provide a structured approach to the management of these patients. The first and the foremost thing is confirming the diagnosis for these patients. So many patients who are labeled as asthmatic, they are found to have some other disease. They are found to have diseases which can cause airway inflammation, similarly, but they are not in the subset of an asthma subtype. So the first aim is to confirm the diagnosis of the patients. The second is to identify the comorbidities. Now we see that obesity, nasal allergies, reflux, these are important comorbidities, which when they are not treated appropriately, we do not get a very proper response to our asthma treatments. The third point and the most important point is adherence. Now, the majority of the people whose asthmas are not being controlled properly, it is due to the poor adherence. The patients do not take regular medications. The patients avoid taking inhalers or inhaled therapies. The patients take it on an on and off basis.
So sorry
When
to
I
interrupt you. Sorry to
yes,
interrupt you, sir. Please
yeah,
make it full screen, sir. You can make it
sorry,
presentation mode.
it's full screen now.
Not yet.
Yes, it's full screen now, sir.
Yes.
Okay, sir.
So I think when we are talking about adherence, it is the doctors who are also responsible for an adherence. We need to educate our patients. We need to inform them when to take inhalers, what is the importance of inhaled therapy, what is the cons of not using the inhalers properly. So this process of adherence, it starts with the treating physician first. Whoever is treating the patient, the first point starts there. If the doctor, the primary care physician who has advised the patient an inhaled therapy, if he counsels the patients very properly, so we won't see so many patients who are suffering from an uncontrolled asthma. We need to optimize their treatment. So optimization means every patient is unique. Every asthma patient is unique. He has a unique set of allergies. He has a unique set of symptoms. He has a unique set of severity. And he might be eosinophilic, he might be IgE mediated, he might have both of these things, or he might be an absolutely Th2 low phenotype of asthma. So every patient is unique, and we need to optimize the treatment as per the patient's requirements, as per the patient's needs. We need to take care about the potential side effects of the therapies. So here I would like to talk about two specific drugs. First is the oral corticosteroids. So when we see the prescriptions, we see that there are a lot of patients who are receiving 3, 4, maybe 5 courses of oral corticosteroids in a year. So India being a country with the second highest population of diabetic patients, we need to make sure that when we are giving therapies, we are knowing the potential side effects. We are balancing the risk versus benefit ratio of our patients. The second drug which I frequently see which is not used properly is montelukast with a levocetirizine combination. I think it is used everywhere. Every patient who has any respiratory issue is being advised to take this therapy. He might be having a pulmonary fibrosis, he might be having a COPD, he might be having an infection. Now, when we are using montelukast, it approximately takes 23 to 24 days for the drug to develop a proper blood serum levels. And only then the action of the drug is being properly generated in our body. It is a leukotriene receptor antagonist. So we see patients who are receiving it for 10 days, 12 days, 5 days. It is not working in that way. The only part of the medication that is working is levocetirizine. Secondly, the newer research has come out which says that montelukast, when used over long periods of time, it can cause neuropsychiatric side effects along with a high potential for suicides and depression. So whenever we are using, we need to take care of the potential risks and benefits for the patients. What I do in my practice is I give them for a period of 3 months, a washout period of 1 month again, and then I restart the therapy. Testing and phenotype identification, as I initially said, we need to tailor made, we need to identify the phenotype. Is the patient suffering from an eosinophilic asthma, he is suffering from IgE mediated asthma, or the patient is suffering from a non-allergic phenotype. Counseling. So asthma treatment per se is quite easy, but the counseling for asthma is quite difficult because of the social stigmas associated with the therapies. The social stigmas, what I face is people come to our clinic and say, sir, do something and ये inhaler छुड़ाने का कोई therapy बताइए. Now, inhaler is considered such a stigma in our society, and I think the healthcare people, the normal general population, they have all created a very big stigma with the inhaled therapies. What I tell the patient is that it is just another way of delivering medication into your body. Like we have injections. Injections can be intramuscular, intravenous, subcutaneous, intradermal. You can have eye drops, you can have ear drops, you can have ointments. So, similarly, an inhaler is a way of delivering the drug into your body. It is nothing else. So, when you explain the patient this way, that you are just giving the same medication, but just another way of providing medication to your body, the patients are more likely to adhere to the therapy. This will result in a better control of their asthma, and it would lead to reduced hospitalization and reduced healthcare visits. To provide opportunities for research and drug trials. In my practice, I have been constantly doing many drug trials on patients with severe eosinophilic asthma, with IgE mediated asthma, which gives us a real time evaluation and real time knowledge about what therapies we are using and what results we are achieving out of that. So these are the core aims when I am talking about a severe asthma clinic, or how do I approach my patients when they come with these asthma or when they are referred to me with uncontrolled symptoms. So as you can see here, sorry, severe asthma and India, the prevalence. So 40%, 98 lakh patients are uncontrolled. Out of them, 67% having more than two exacerbations. You can imagine a patient with asthma who has two exacerbations, he would be spending more than 1.5 to 2 lakh rupees in a year only on asthma, which can be very easily treated. 58% of the asthmatics in our country, they have an increase in peripheral eosinophilic count. It can be due to a multitude of reasons. One main reason is this is the genetic population of our country, and we all have some similar genetics, which is predominantly uh, showing up in the eosinophil count. This asthma patients, when we talk about the sputum eosinophil count, which is a very, very important thing. When we are phenotyping the patients, we even do their sputum eosinophil count. So there is a very high proportion of patients, 26.3% of patients, they have a high sputum eosinophil count in our country. So a structured approach to a management when we are dealing with a patient of asthma, I'm not specifically talking for severe asthma or difficult to treat asthma. Any patient who comes to us with a history of asthma or symptoms and signs suggestive of asthma, the first point, confirm the diagnosis. Please do not label anyone an asthmatic before getting a proper history, a proper examination, a proper family history, exposure history. After that, once we have made up our mind or we have some provisional diagnosis of asthma in our mind, we should get the patient's pulmonary function test done by spirometry, which should be done before and after the use of a bronchodilator to see for the reversibility in FEV1, which according to the guidelines should be minimum 12% or 200 ml, whichever is better. Peak expiratory flow variability. Now, this is something which I don't think so is possible in our country because this would lead to more and more emotional burden on our patients. Allergy testing in reserved cases where we are not getting the desired result, where we are not getting a response to therapy. After your diagnosis, the most important point is making sure that the patient adheres to treatment. And it takes a lot of time. It approximately takes for each patient of asthma at least 20 minutes of counseling, 20 minutes of explaining them why they need to take their asthma medications regularly, why they need to follow up regularly, why they need to take their inhalers regularly. It takes approximately 15 to 20 minutes. But those 20 minutes would actually save the patient at least one hospitalization per year. Self-management skills. We need to have a proper inhaler technique. We need to explain the patients whichever drug we are using, whichever way we are using. The patients need to understand how to properly use the inhaled medication. Written action plans. These are for exacerbations where we can ask our patients to do a following set of things before reaching out to them. To also assess that the patient does not have a continuous exposure to the allergen which is triggering their asthma. So if a person is allergic to dog dander and he has a pet dog at his home, then you do not expect even with your best medication the patient asthma to be controlled, or the patient has some workspace related exposure, the patient has some issues like smoking, the patient has issues related to inhalation of toxic dust in or chemicals in the environment. So the allergen or the trigger should also be found out and it should be removed, tried to remove at least. We have to treat the comorbidities such as obstructive sleep apnea, GERD, which is reflux, blood pressure, bronchiectasis, which can cause repeated infection and increase flare up of asthmas. And we can also give them a trial of add-on therapies. There are a lot of add-on therapies available in the market, but these are again reserved for patients who do not respond. And what I feel is 99% of the patients, they respond to the standard 2 or 3 medication. It is just the time which we need to give to our patients. The patient flow to a
So
severe asthma clinic.
with due
Sorry.
respect, sir, 2 to 3 minutes more, sir. Thank you.
Okay. So I'll directly be going on the case now. Okay. So this is a case of a 56-year-old male who was referred for the management of asthma. His asthma has been difficult and difficult to control since a very long time. He has been diagnosed 10 years ago. He had nasal symptoms He had a bronchiectasis. He had received multiple doses of intravenous antibiotics, and he required occasional steroids also for improvement in his symptoms and his quality of life. Although he had excellent benefit from OCS, but we always knew that we can't give OCS or oral corticosteroid for a long period of time. His treatment regimen was escalated to include maintenance oral corticosteroids. So he, without the oral corticosteroids regularly, his asthma was not controlled. These were the medications he was using: prednisolone, high dose ICS, LABA, LAMA, nasal sprays, Montelukast, calcium to because the patient was on steroids, and ristonate to prevent osteoporosis because of prednisolone. So he had a prior history of surgery for nasal polyposis. He is a never smoker and unable to work since the diagnosis of asthma. The cardiac workup was normal, current cardiac workups. He was obese on examination. The ACQ score was 3.3, which suggested very poor asthma control. Inhaler technique was good, but still his asthma was uncontrolled. FEV1 was quite low, 50%. There was only a small improvement after giving them inhaled beta 2 agonist. The eosinophil count were quite high, about 200 cells per microliter. Actual counts were 230 cells per microliter. His FeNO, which is a fractional exhaled nitric oxide, this is not done for each and every asthma patient. This is done for patients who are difficult to treat or who are on oral corticosteroids and not being able to taper down. So it was quite high. Above 50 is considered significant. So his was 81 parts per billion. So is it difficult or severe asthma? So this patient has comorbidities management, which was done. Inhaler technique was done. Compliance was done. His FEV1 was 50%. So he was on the borderline of moderate to severe. So the phenotype was he was a late onset and difficult from onset as asthma. He had nasal polyposis, but very good response to oral corticosteroids. And he was a Th2 phenotype because his eosinophils were high and pheno was also high. So diagnosis was eosinophilic asthma, which is severe. Comorbidities we have already discussed. So what was the patient-related concerns? The symptoms what he was suffering from: OCS dependence, poor quality of life, recurrent exacerbation. So he was a stage 5 patient, and he was on stage 5 therapies. So what can we do in such patients? So in such patients who are on oral corticosteroids or who are very difficult to manage, who have frequent exacerbation, we have biologicals. And specifically for eosinophils, we have two biologicals available, which are the anti-IL-5 therapy, mepolizumab, and IL-5 receptor blockers, which is benralizumab. So the diagnosis of type 2 severe eosinophilic asthma was made in 2020. When the patient was seen, he was started on mepolizumab. At that time, benralizumab was not available in the market. Initially, the patient responded very well. Okay. Now the patient's steroid requirement could decrease. The patient was having reduced exacerbations, and his mepolizumab was continued. By January 2021, with the mepolizumab therapy, his OCS therapy was reduced gradually, and by sooner his dose was reduced to 2.5 milligram per daily. He was advised to withdraw oral corticosteroids. Now, as soon as the oral corticosteroids were withdrawn, he again started developing symptoms. His pheno was improved, but after a period of time, a decision was taken that the patient was shifted to benralizumab, which is a more potent drug, which causes an absolute clearing of eosinophils, not only from your blood, but also from your bronchial walls, which is an added advantage. Benralizumab has an advantage of giving a persistent and a prolonged response even after stopping the medication. It causes an improvement in the pulmonary function test starting from week 24, which is sustained for a very long period of time. So because of the shortage of time, I am just focusing on the slides which are actually very relevant and which would be helpful. So patients on mepolizumab, they were what we used to see was neutrophilic exacerbation. So I'll repeat again, we have two drugs available for eosinophilic asthma. Mepolizumab, which is an IL-5 IL-5 anti-IL-5, and benralizumab, which is an IL-5 receptor blocker. So in mepolizumab, the patients used to still have neutrophilic exacerbations, and it required oral corticosteroids because the patients would already be on anti-eosinophilic therapy, so they needed something else to provide them benefit. So steroids were required. When there was breakthrough eosinophilic exacerbations also, but they used to respond only and only to oral corticosteroids. His biological therapy was then switched to benralizumab. He confirmed improvement in his asthma symptoms and no requirement of any rescue steroids on and off. His lung function test, his blood eosinophil count all revealed improvement. According to ENT specialists, the patient also achieved a better control of nasal symptoms with benralizumab. But his nasal steroids were continued, the topical steroids. He currently remains free and exacerbation free. In this case, the FeNO was elevated with white blood eosinophil count more than 100 after OCS withdrawal, highly suggesting an eosinophilic phenotype of the exacerbation events. The treatment response to benralizumab led to a very good patient response as it was anticipated. And we also saw that the FeNO levels could be reduced, the blood eosinophil count reduced, and potentially more appropriate strategies, including long-term macrolide therapy or reducing ICS dose rather than switching the biological therapy. So key learning points are poor adherence to background inhaled corticosteroids is common. It needs to be identified and this should be optimized before any biological therapy. The inhaler monitoring aligned with biomarker profiling such as FeNO, eosinophil count is very helpful in choosing the optimal therapy option for these patients. Adrenal suppression is common in these patients who are receiving maintenance oral corticosteroids. So as OCS is being withdrawn after initiation of biological therapy, adrenal function needs to be measured and addressed. The PONENT study has provided a useful management in patients with severe eosinophilic asthma who continue to exacerbate on biological therapy. We need to review our biologics if the patient is on biologics which are not phenotyped properly. We need to make sure the patient is receiving at a proper dosage and proper intervals, and individualized decision making, such as when we should consider switching to another therapy, as this patient was switched from mepolizumab to benralizumab and he saw an improvement. Both the drugs act on eosinophil but with different mechanisms, so every patient should be treated individually with individual set of uh, tailored treatment. Thank you so much for your attention.
Thank you so much, Dr. Jalan. That was a wonderful session. Altogether, a new insight. Since we are running short of time, should we move to the next session or we can have one or two questions?
No, I think nobody has questions.
Okay. With due permission from Preeti ma'am and Dr. Geeta, we move to the last session of the day with Dr. Parag Shah, an endocrinologist who will have an insight in management of CKD in diabetes. So to introduce Dr. Parag Shah, I kindly request Dr. Deepa Rawal to take over from this point. Over to Dr. Deepa Rawal.
Good evening, all in one present over there in this webinar. I'm Dr. Deepa. It's my privilege to introduce Dr. Parag Shah, who is an eminent endocrinologist. Dr. Shah is a consultant endocrinologist for last 20 years of Gujarat Endocrine Center, Ahmedabad. He has done his is DM and DNB from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. He has more than 55 publications in index reputed journals. He has been organizing secretary of ESICON 2015. It's the annual conference of Endocrine Society of India, Ahmedabad. Today, he is going to talk about importance of an early CKD management, which is very essential for type 2 diabetes patient. Over to Dr. Paraksha.
Good afternoon, everyone.
So we have next 15 minutes with Dr. Parag Shah on management of CKD in diabetes. Over to Dr. Parag Shah.
Yeah, can you see the slides?
Yes.
Yes, sir.
Yeah. Okay, so I will try to finish my talk in 15 minutes. So we finish actually on time. So these are very typical patient, type 2 diabetic for 5 years, dyslipidemic, hypertension, diabetic retinopathy, hypoglycemic episodes on sulfonylureas, is already on gliptin metformin and RAS blockade and the statin with a reasonably good glycemic control and elevated LDL cholesterol. Blood pressure is well controlled on the diuretics and the RAS blockade. But just like many of our patients, his renal status has not been evaluated. So what is the importance of early CKD diagnosis? I don't want to bore you with the numbers, but prevalence is quite high actually. It's underreported not only in our country, but globally also, that it is quite underreported. If you see, the mortality related to the CKD is increasing because of the various reasons. One is that we got a good longevity along with the chronic disease, and we don't have a very short treatment which will prevent the deterioration of the renal dysfunctions. Unlike, like for example, the CAD, we got a PTC and the CABG, for example. So number of mortality attributed to the CKD is likely to be increased. The key to prevent this morbidity as well as the mortality is to diagnose them early. Like if you start screening them early, you can screen 51% of the patient at the stage 1. But actually in a real practice, practically only 5% of the patients are diagnosed at stage 1 and stage 2. These are the stage where we can do the best possible management to prevent the deterioration and ending the patient, landing the patient with the end stage renal disease. So a strategy of a CKD screening is there for the diabetic, hypertension, CAD patients, or in our country, lots of patients are using the nephrotoxic drugs. Lots of patients are using the NSAIDs of their own. Older age, obesity, prior AKI, obstructive uropathy are the people who are likely to have a more chance of the chronic kidney disease patients. And if you diagnose the CKD early, like this data of around 27,000 patients from the US database, and you intervene in time, you can significantly reduce the deterioration of the renal dysfunctions. Like you can see this in a graphical manner, that if you start seeing the patient at a EGFR of 100, and if you notice that EGFR is dropping to the 50, and you start having the intervention at that point of time where EGFR has dropped to 50, then probably patients end stage kidney disease would occur at 9 years of age. But as soon as it touches the early CKD stage, and if you do the proper intervention, this can be significantly prolonged. So if this patient, if you do the renal status by doing the EGFR or a creatinine and urinary albumin creatinine ratio, both are complementary, both are independent, and both are equally important to judge the prognosis of the patients. Like this patient has a EGFR of 55 and urinary albumin creatinine ratio is 60. So it's got a macroalbuminuria with a stage 2A EGFR drop. So these are the patients who is on this stage. So in spite of best possible treatment, just like dyslipidemia management, in spite of good lipid management, we got a huge residual risk of the CAD. Similarly, for the CKD, in spite of having a good glycemic control, good blood pressure control, good lipid control, good RAS blockade, good role of a aspirin in a non-ischemic patients, still we got a huge residual risk of 56% where patients might have a further deterioration of the renal dysfunctions. So start thinking beyond the glucose control alone in a diabetic population, act early to diagnose the CKD. And CKD, as we know, that microalbuminuria is not just a marker of a renal dysfunction, it is marker of a potential cardiac dysfunctions also. So act early to protect the kidney and heart in a diabetic populations. So what are the guideline recommendations for the treatment approach? Apart from the lifestyle modification and a first line drug therapy for a diabetic patients to prevent the macro and macrovascular complication is the metformin, SGLT2 inhibitors, RAS blockade, and the statin. On top of that, the patient has early signs of the renal dysfunctions. There is a role of a non-steroidal MS or finerenone or a GLP-1 receptor agonist. So if the patient's glycemia is not controlled with the metformin with SGLT2 inhibitor, we can add the other agents, but the background should be metformin and SGLT2 inhibitors. But if the eGFR is less than 45, then we have to reduce the dose of the metformin. And once it goes to below 30, then we have to discontinue the metformin therapy. So 2022 ADA guidelines suggest that if the patient has a CKD and albuminuria, use SGLT2 inhibitor with the primary data to suggest reduction of the CKD progressions, or if you don't have a data, at least CVOT trial showing the CKD progression reductions, or patient is not tolerated SGLT2 inhibitor, or for any reason it is a contraindicated, then the second option would be the GLP-1 receptor agonist. And sometimes we have to give both because both have a complementary mode of actions. So among the SGLT2 inhibitors, predominantly we got a 3 SGLT2 inhibitors. One is the DAPA, second is EMPA, and third is the canagliflozins. And we got a excellent cardiovascular outcome trials with this 3 SGLT2 inhibitor like EMPA-REG outcome trial, CANVAS trial with the canagliflozins, and the DECLARE with the dapagliflozin. But EMPA-REG outcome was predominantly a secondary prevention trial where all the patients had a established ASCVD, and the baseline eGFR was more than 30, which was required. CANVAS, again, 65% patients had a ASCVD and 34% patient had a multiple risk factor for the atherosclerotic cardiovascular disease. By the DECLARE, which is a large population of around 7,000 patients, only 40% had established ASCVD and 60% had a multiple risk factors. So we got a 17,000 patients populations, out of which 7,000 had a ASCVD and around 10,000 plus patients had a multiple risk factors. And you can see this is a relatively less risky populations. Like if you see the cardiac event rate, like EMPA-REG in 1,000 patient years, around 44 major cardiac events is likely to occur, while with DECLARE with the DAPA, it is only 24. So it is almost the half. So it is a relatively less morbid populations with a primary as well as the secondary prevention type of the strategy was employed. So we all know that gradually, as the diabetes duration increases, there is an increased risk of the heart failure hospitalization, CKD, cardiorenal events, and ultimately the mortality. So we have to start acting probably at this preventive stage. And if you cannot, we should be having a good therapeutic window also available with us. But it's always said that prevention is better than the cure. Like DECLARE TIMI study, as I mentioned, with a better eGFR to start with like baseline eGFR was 85, almost normal, and microalbuminuria was only 30. So relatively stable renal subset of the patients. Even then, you can see that when we give the dapagliflozin, the renal deterioration was significantly prevented when the patient was on a dapagliflozin. Around 47% relative reduction was there. And this renal benefit was irrespective of the baseline eGFR or whether patient was having a established CVD or the MRF. So irrespective of the comorbid conditions, the giving the dapagliflozin could prevent heart as well as the kidney in the DECLARE TIMI studies. So what about the deterioration of the albuminuria? Like normal albuminuria to micro or a macroalbuminuria stage significantly prevented with the dapagliflozin. That patient did not have a further deterioration of the albuminuria or less chance of deterioration with the DAPA compared to the standard of care therapy. What about the reversal? The DEPA has shown some reversal also, like microalbuminuria patient turning into normal albuminuria, macro turning into the either normal, the micro, or macro turning into the micro or the normo. So you can see here all the chances of having a, even reversal was more with the dapagliflozin. So it showed a good preventive strategy when we started early. What about the established CKD patients? So declaratimi was a predominantly a good renal function to start with. Like, while we got a dedicated trial called DAPA CKD of around 4,300 patients, half the group was given 10 milligram of the DAPA and half the patients were given the standard of care, and median follow-up was around 2.5 years. The EGFR more than 45 were there in 41% of the patients and less than 45 in around 60% of the patient. USER was 200 to 5,000, and DEPA therapy could be continued following even dialysis initiation. So you don't start DEPA when patient is on a EGFR of less than 25, but if somebody is already on a DAPA, you can continue even during the dialysis stage. And here they included all types of the kidney disease patients, not only just the diabetic kidney disease patients. And what was the primary composite endpoint? Like 40% relative reduction of cardiovascular renal major events. All-cause mortality was reduced by 31%, and CV death or hospital for heart failure was reduced by 30% of the patients. So it showed a good, you can see here number needed to treat was just 19. You need to treat just 19 patients for 3 years to prevent one major deterioration of the renal dysfunction, meaning thereby more than 50% drop of the EGFR, end-stage kidney disease, or the cardiovascular or the renal mortality. Whether diabetic or non-diabetic kidney disease patients had some difference, primary composite outpoint significantly reduced even if somebody had a non-diabetic kidney disease CKD, and same was there with the all-cause mortality actually, and CV death or HHF also was reduced. Actually, if you can see this primary composite outcome and all-cause mortality was actually better reduced with the patient with a non-diabetic kidney disease, probably because the diabetic patient has a multiple atherosclerotic micro and macrovascular diseases, and non-diabetic kidney disease sometimes are the patient who had only one abnormality, that is a chronic kidney disease populations. So if you compare the DEPA CKD and the EMPA kidney studies, both showed a significant reduction of the major renal deteriorations, and number needed to treat with the DEPA was 19, while with the EMPA was 27. All-cause mortality reduction was seen only with the DEPA, not with the EMPA, nor with the canagliflozin. Composite of the cardiovascular death or hospital for heart failure again was reduced only with the DEPA CKD with the DEPA and not with the EMPA, and all-cause hospitalization was reduced by both DEPA as well as the empagliflozins. So among the different agents which are available with us, which shows the maximum renoprotective benefits in preventing the progression of the renal composite outcomes in a patient with a type 2 diabetes. This is a meta-analysis showing that DEPA shows the maximum benefit followed by the empagliflozins. So now we got a lots of dapagliflozin available. We got a branded generic, we got a generics, and we got a patented dapagliflozins. So India is a price sensitive country, so we always consider cost of the therapy as the important parameter. But what are the scientific data? What is the difference between generics and the patented molecules? Generics bioavailability may range for minus 20% to plus 25%. That is officially allowed not only in India, globally also, that you can have 20% less bioavailability or 25% more bioavailability. So naturally, the efficacy as well as the side effects profile might be different with a generics versus the patented molecules. What about the Forxiga versus other dapagliflozins? We got a huge data like declared DAPA-HF and the DAPA-CKD with the original Forxiga, and we don't have naturally the data with the generic dapagliflozins. But what is the evidence of original versus generic molecules for that matter? And this is the study from our own country, that DAPA generic versus DAPA innovators. And you can see here the A1C efficacy was 0.76 with the DAPA generic and 1.26 with the innovator DAPA, that is a Forxiga. And the side effect profile, specifically genital mycotic infections, were more with the generic compared to the original. What about the statins, generic versus the branded statins? Higher probability of suffering a cardiovascular event for the generics compared to the innovator statins. So again, it shows that even with the statin, there is a difference between, this is a real world data actually. And you can see more than twofold increase in the stent thrombosis with the generic clopidogrel versus branded clopidogrel. So probably the patented and the molecules and the vehicles used to deliver that molecule probably matters in a lots of study. Like this is a chronic pulmonary aspergillosis, a study from the PGI Chandigarh, around 200 patients with the CPA branded versus generic therapy. You can see that 2 weeks of the interval, the therapeutic drug levels achieved was significantly better with the innovator itraconizoles versus generic itraconizoles. So if you see our patients back who had a high cardiorenal risk based on this EGFR and USER plus diabetic dyslipidemia, hypertension, and background diabetic retinopathy, probably is the ideal candidate to be put on the SGLT2 inhibitor and preferably on the dapagliflozin. So if I summarize my talk, CKD is highly prevalent, but underdiagnosed not only in our country, globally also. We have to be more vigilant in our country because patients sometimes stop the medications of their own, take some generic, takes the over-the-counter medication, take some other pathy medications, which we don't know whether they are nephrotoxic or not. So we have to be more vigilant in our country about the renal status of the patient with the each probable visit with us. Guideline recommended early use of the SGLT2 inhibitor in type 2 diabetic patients having renal disease. Now it is recommended even for the patient with a heart failure also. DAPA has significant data to show the renal protection, whether patient had a early, moderate, or a severe CKD. It shows the persistent benefit, not only for the renal point of view, but reduction into the all-cause mortality, reduction into the hospitalization for heart failure, and cardiovascular mortality also. The quality of evidence exists with the original innovative products. So if the patient can afford, and patient is a high-risk populations, try to convince the patient to take the studied patented molecules. Thank you very much for your patience hearing.
Thank you so much, sir. That was a lucid talk. Wonderful explanation, sir. Definitely, original is original. No second thoughts about, and definite role of DAPA in management of CKD and diabetes, and where we can place and how it is superior to other SGLT2 inhibitors have also been wonderfully explained. So thank you so much. Any questions for sir?
At this point, on the endless code channel, can you see any questions? Rahul, Nimesh? On the viewers channel, are there any questions?
I think Dr. Parag will agree with me that after metformin in treatment of diabetes, SGLT2 inhibitor should be the second priority after metformin.
Yes,
What
I
do you
think with the significant metabolic benefit in terms of the sustained A1C drop, some reduction into blood pressure, weight loss, some reduction into the uric acid values, and good cardiorenal protections, no risk of hypoglycemia. I think it makes the excellent choice. Not after metformin, I would say along with the metformin. I think the era of a metformin as a monotherapy is gone actually. I don't think that we should be now using metformin as a monotherapy because it takes care of only one major pathophysiology, that is a hepatic resistance. While we are now trying to address as many pathophysiology as possible, and we are moving away from just glycemic control to overall health of the patients, and most common is the cardiac and the renal problems, which is more common in the diabetic populations.
So true, sir. So true.
Where do you recommend finerenone in early CKD?
Yeah, I think the patient has a albuminuria and patient is on a RAS blockade and you want to reduce the risk. I think along with the SGLT inhibitor, if the potassium is permitting, finerenone is the excellent agent. And I used lots of finerenone, and hyperkalemia is actually very, very infrequent. I hardly remember anybody whom I have to stop the finerenone because of the hyperkalemia. This is like a RAS blockade. When it came, we were so much worried about the hyperkalemia. Now we see that except high risk populations, we don't see that frequent hyperkalemia in a patient who's on a RAS blockade. Initially, I remember that when the RAS blockade was introduced, after 2 weeks, we used to ask the patient to get the potassium done. Now we don't do it that frequently. Only after like routine 3 monthly visits, we measure the creatinine and the potassium. So I think it's an excellent agent. It is supplementary agent. It's not like a substitute for SGLT2 inhibitor. So I think SGLT2 inhibitor, finerenone, and the RAS blockade, along with the good metabolic control of diabetes, blood pressure, and dyslipidemia, I think that these four are the cornerstone of the CKD management.
Nimesh, any questions on the viewers?
No, ma'am, I'm not able to see chat box, but Rahul, if you can help us.
Okay, thank you, Nimesh. So if there are no questions from the panelists, shall we end the session? Dr. Jagnani?
Sure, ma'am. Sure, ma'am. We had
Yes,
four
ma'am.
wonderful lectures
Yes.
from cardiologists, endocrinologists, and pulmonologists. A new insight in these diseases, the role of various newer molecules in management with the current guidelines. I would like to thank all the eminent speakers from our side on behalf of FFPAI for organizing this wonderful CME, and also would like to thank Astra for doing this platform, using this platform, and we have been definitely benefited with these talks. Thank you so much, our chairpersons, our speakers, the platform, the academic sessions, the event, and the pharma people. Thank you so much.
Thank you, AstraZeneca, for sponsoring the event. Thank you very much. And Edlaysco Technology for giving us the technology platform for this webinar. Thank you all the panelists, Dr. Sanjay, Dr. Deepa, Dr. Geeta Lodh, and all the speakers. Each of them were par excellence, outbeat the other.
Thank you,
very
madam. Thank you.
much.
Thank you, everyone. Good day.
Thank
Good
you.
day.
Thank you, everyone.
Thank you so much.